Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is August 19, 2025. This review is on diverticulitis, published recently in JAMA, July 24, 2025. How common is diverticulitis in the US? 180 per 100,000 annually, about 200,000 admissions, and it's estimated it's over 6.3 billion in cost. How many with diverticulosis develop diverticulitis? 1 to 4% lifetime risk. What's the recurrence rate? 15 to 30% after the first episode. Why do diverticula form? Weak colonic wall points, especially sigmoid colon, and this is a result of Laplace's law. What causes diverticulitis? Fecal impaction, microperforation, and gut dysbiosis. What are the risk factors? Age above 65 years, obesity, high blood pressure, diabetes, steroids, NSAIDs, opioids, and connective tissue disorders. Do lifestyle factors matter? Nuts and seeds are safe. High physical activity lowers risk by about 25%. How is diverticulitis classified? Uncomplicated, about 85%, versus complicated, those complicated by an abscess, a fistula, a stricture, or perforation. What are Hinchey stages? The stage from 0 to 4, ranging from localized inflammation to fecal peritonitis. What are the common symptoms? Left lower quadrant pain in 70%, nausea and vomiting in 30%, fever in 33%, and leukocytosis in 55%. How do older adults present? Less typical, often no fever or leukocytosis. What is the gold standard test? Contrast enhanced CT. Sensitivity 98 to 99%, specificity 99 to 100%. What other imaging is used? Ultrasound, sensitivity 77 to 98%, MRI, sensitivity 86 to 94%. MRI is preferred in pregnancy. Is colonoscopy used? Not acutely. Safe 6 to 8 weeks later if required. Management and complications. Is antibiotics always used? No, not in uncomplicated immunocompetent cases without systemic symptoms. Who should get antibiotics? Patients above the age of 80 years, pregnant women, immunocompromised with comorbidities or systemic illness. What are the first line antibiotics? Oral amoxicillin with clav, cefalexin plus metronidazole, Cipro plus metronidazole, IV cefotraxone plus metronidazole, piptazo, and carbapenems. How is pain managed? Acetaminophen is preferred. Avoid NSAIDs. Opioids short term if severe. What's the recurrence risk? 13 to 23% in uncomplicated and up to 40% in complicated. When is surgery indicated? Recurrent diverticulitis greater than 3 in 2 years, persistent symptoms, fistula, stricture, and perforation. What are the surgical options? Hartmann's procedure versus primary anastomosis. Latter is associated with better stoma-free survival. Special populations. What about younger patients below the age of 50 years? Higher recurrence, complications, obesity is common, often need early surgery. What about older patients above the age of 80? Atypical symptoms, higher post-op mortality up to 17.8%. What about immunocompromised? Higher complication, infection, and mortality 10 to 19% versus 1%. That's in a nutshell the JAMA review. Eponyms in diverticulitis include Hinchey classification, developed by Edward Hinchey in 1978. Stages 1 to 4, pericolic abscess is stage 1 to fecal peritonitis stage 4. still used for clinical decision making. Hartmann's procedure, Henry Albert Hartmann, 1921, sigmoidectomy plus end colostomy plus rectal stump closure, first described for cancer, now common in complicated diverticulitis. What's Laplace's law? Pierre Simon Laplace, 1749 to 1827, Frenchman, who described wall tension is equal to pressure into radius. Sigmoid colon, small radius, high pressure. No wonder it's the most common site of diverticulitis along the intestines. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master Medfax at mastermedfax.com.